Hi, I'm Dr. Jim Del Rosso, a dermatologist in clinical practice in Las Vegas, Nevada, and also director research center here. And I'm very involved in a lot of disease states, and one of those is atopic dermatitis, which is obviously getting a lot of attention with new therapies and better understanding of the pathophysiology of the disease. But I think there really is a need for a reality check when we're looking specifically at selecting Janus kinase inhibitors. We have the oral agents, which can provide some significant advantages in patients, giving us very, very good results in terms of improving the eczematous dermatitis and the itching over and above to some extent what we have with other treatments. Though we do with the monoclonal antibodies, we do have excellent treatments, as everybody knows, but sometimes patients need more. And we're seeing them right out of the chute. They've had other treatments, they've had a difficult time, and they're miserable. And oral Janus kinase inhibitors like upadacitinib and abrocitinib are often very helpful, but they carry the baggage of, even though it may be rare in the safer populations of healthier patients that are younger with atopic dermatitis, we still have to be cognizant of some of the systemic effects that you might get. And there's a variety of those, and some of them are listed in the black box warnings. Now, topical ruxolitinib cream, 1.5% cream, applied twice a day for atopic dermatitis in patients that have not responded to other treatments, other topicals, and still having difficulty. It's a different situation, even though the black box warnings are in that package insert because of class labeling. It's not because events occurred to any significant degree. And I think the reality check is, if you look at the data, if you look at the maximum use application studies with the ruxolitinib cream, the average body surface area was 37%. They had to have at least 25% body surface area. In the clinical trials, you're about 9%. How much topical cream are you going to put on patients with atopic dermatitis? They're going to have more limited disease. And even if you're utilizing a systemic treatment, they have breakthrough areas because even the systemic treatments don't ever get everybody 100% clear 100% of the time indefinitely. So topical therapy is a mainstay, and what topical ruxolitinib offers is a therapy that works very effectively. It could be used in any area of the body. With if the skin is involved and affected with atopic dermatitis, the treatment can be used. I think works very well in the face, is safe around the eyelids. A significant number of patients in the trials had the disease on the face. So you're talking about, in reality, you're getting nowhere near the amount of application where you would have to be truly concerned about one of the systemic side effects. So I think that's a big advantage of that particular treatment. And in practice, it's working out to mirror what we've seen in the clinical studies. And irritation levels are very low, even in a population like atopic dermatitis, where their skin is sensitive, and sometimes irritation is a problem with some of the topical agents. So I think the reality check is that the topical agent gets very high concentrations in skin, limited systemic exposure, especially when we look at the amount of body surface area we'll typically be using the treatment.